Hello, everyone. Welcome to today's Phlebotomy Webinar. My name is Sierra Tollefson, an education specialist for Mayo Clinic Laboratories. Our presentation today is Mission Not Impossible, Overcoming Challenging Pediatric Draws. Our presenters are Jennifer Rodemeyer, a Child Life Program Manager in the Department of Pediatric Nursing, and Ryan Halda, a Supervisor of Pediatric Phlebotomy in the Department of Laboratory Medicine and Pathology, both at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone of before we begin today. I will be dropping the link to the handouts in the chat shortly. You can download those at your convenience. There will be a question and answer session at the end of the program. You can submit questions online via the Q&A icon in Zoom. Please only use the chat function for any technical issues. Today's program is being recorded and will be posted to our website in a few weeks. With that, I'll turn things over to our presenters.
Thank you for that introduction. Welcome to our presentation, Mission Not Impossible, Overcoming Challenging Pediatric Draws. For all you that perform procedures within the pediatric population, I want to say bravo. It takes a special person to want to care for children that scream, act out, and frankly don't like us because we're about to poke them. Why do we do it? For me, it's knowing that we're making a difference with the care team to help these kids get better, but also to show them what we do isn't scary. Pediatric phlebotomy can be challenging in itself, and when you throw in different situations like a parent saying, just pin them down and get this done, it just adds to the stress. So what are some ways that we can overcome some of these added challenges? Today, we'll discuss a couple of common challenges that we all face in our daily profession, and to give you some resources to make it a little bit easier on everybody involved. And as you can see, we have nothing to disclose in our presentation. The objectives for this presentation is, upon completion of this presentation, participants should be able to differentiate behavioral consideration amongst various age groups within the pediatric population, to be able to understand various perspectives through assessment in order to make a positive collection for all that are involved, and also identify resources needed in your current practice in order to support the pediatric population. First thing that we like to discuss is children's fears. Children from babies to even to adolescents have many different fears. We kind of came up with a top 10 fears. And as I read these, try to think of what these all have in common. So you got darkness, strangers, being alone, hospitals, the sight of blood, going to the doctor, to the dentist, angry people, disapproval, failure, people with special needs, and making mistakes. So what do these all have in common? The main thing that these have in common is they can all happen in one location. By just going to the doctor and having a simple lab draw, this child can be having so many different fears, not just one. So it's things that we really take into consideration, that they, at this age, they're not able to understand what's a real fear and what's not. So when you have all these compounded together, it can be very stressful on that child. And just knowing that going into will help kind of understand and even feel a little more for that child. In addition to that, we took and talked to several of our patients and kind of asked, what do you hear when you hear the word poke? What do you feel? Because it's very important to know that the words that we choose to use mean so many different things to every kid. You can see in this wordle here that we have a lot of common things: needle, ouch, blood, sharp, scary, jab, so a lot of different things. But then you also have unique things. Feels like a hot glue gun was left on my arm too long, or mom and dad hold my hand, get that thing away from me. So you got a lot of different views of the word poke, even in everyday words that we use for them. Just really be mindful of the words that you choose to use, because they can really mean so much different to everybody. So throughout this presentation, there are certain things that we want to consider when working with the pediatrics. We want to focus on their development considerations. Are we thinking of their age group and what considerations that we should be concerned about with their development? The caregiver, how much do we want to get them involved? And then resources needed for a successful lab draw. So things that we're thinking about there is the equipment that you're using, the environment that you're going to put them in. What do you have for pain relieving options at your facility? So what are you going to use to be able to make that a little bit easier for the child? Preparation. Are you prepared? Is the patient prepared? Is the parents prepared? So really having that preparation to be able to make sure everybody's on the same page and we're able to help have a successful lab draw. Also, what appropriate comfort position are you going to use? There's many different comfort positions that we'll talk about later in the presentation, and what is going to be appropriate for the child and for the situation that you're in. It all comes down to really creating that plan and making sure that you have a plan from start to finish, and that's going to be able to create the best experience for all that are involved.
So like Ryan had shared earlier, I'm Jen Rodemeyer, the Child Life Manager here at Mayo Clinic Children's, and I just want to acknowledge, I realize that not everybody has access to a child life specialist that works with you on a daily basis. We're very fortunate to have that resource available to many areas here in the clinic. But today, the things that I'm going to share with you are going to be those resources that we use and those little tricks and tips that we use to help create those positive coping plans in patients. So why do we do what we do? Why don't we, just like Ryan had said earlier, just get it done and go in and quickly poke that patient? Well, research shows that 1 out of 10 adults refrain from having medical treatments as an adult because of something that they've experienced as a child. So how can we avoid those opportunities, those missed opportunities right now? And even though we think, oh, the procedure won't last long, let's just go get it done, we see that these play those long-term effects later on for patients in life. How could we learn best? Let's learn directly from kids itself. This is a patient that's been coming to our hospital for the past 3.5 years. I'd love for you to take a listen to what Christian has to say about when he comes to the lab and gets his pokes.
All right. Can you tell me your name?
Christian.
And Christian, how old are you?
6 years old.
6 years old. So when you come to the lab, what helps you?
To not hold me down when I get access. And I talk to one person, talk to me one instead of a lot of people.
Yeah. What else helps you? What do we put on your port? What do we put on it before we do it? Is there something we put on it to help make you not feel it?
Cream.
Your cream, that's right. Yeah, those are good answers. What would you like the staff to remember when you have to get your port accessed? What do you want the team who comes in to remember?
To not do it very hard.
Not do it very hard. Yeah, anything else? No? Okay. And then what would you tell other kids that have to get pokes? What would you tell them to do to make it easier?
Look on the iPad from the people that have the iPads.
Yeah.
And you would be distracted.
Distracted? Yeah.
You won't really feel it from the cream too.
Oh, you don't feel it from the cream too? Okay. Do you think that pokes are easy now or hard?
I don't really like pokes.
You don't
that
like
much.
Yeah. Do you think, though, you have a plan to make them easier?
Yeah.
Yeah. Awesome. Good job.
I love Christian's honesty, and I think we can learn a lot from him. I still to this day have yet to meet someone that likes to get pokes, and I love how he just says that. But the cool thing about sharing that video with you is we've come a long way in the past 3.5 years with him. So upon his diagnosis, he was admitted straight to our PICU. He was poked quite frequently in that setting. We went from having to wear a smiley face on our shirts by saying that we aren't going to do any pokes, to having to wear a Band-Aid at times when pokes would happen, because that's how scared he was about people coming in and out of his room. From the PICU, he transitioned to Gen Peds, and then eventually transitioned to the outpatient unit, and then became back and forth into the hospital throughout his treatment. And throughout that, we established this coping plan. And as you can see from what he had to share, Christian is able to verbalize what he needs to help him cope. And so the goal for us is to establish these healthy coping plans. So even when the kids aren't in our facility, but have to go to another facility for care, they know what works for them. So how do we do this? By taking a look at their development. We're going to start by looking at infants and take a couple notes about them specifically. So on the average day of an admission, an infant has somebody in and out of their room 54 times. When you think about them just having one or maybe two consistent primary caregivers, that's a lot of people that are coming in and out. What do we need to do to help support the infant and toddler? We need to make sure that we have a consistent caregiver. So have the parent, have the caregiver invited in to be a part of their care. We need to reduce the amount of stimulation for these kids because they just actually came from utero and now they're in the world and there's all these extra noises, lights, and sound. Destimulate that as much as possible. And working with toddlers and preschoolers, I think this is one of my most favorite groups that I like to work with because of their magical thinking. Kids at this age think, their minds can wander and they can have these fantasies about situations. And so how do we bring them back to reality? We offer them honest information, and we need to help their misconceptions that they might have. I was working in our emergency department one night with a resident, and he was thinking he was making this quick connection with this kid, when in the end, it was pretty funny how it turned out. I'll share with you what happened. He grabbed his otoscope, he turned to the child, and he was going to go do an ear exam, and he said to her, "Let's see how many pink elephants you have living inside your ear." The girl's eyes got really big. She turned to me, she turned to her mom, and she said to her mom, "You never told me that I have pink elephants that live inside my ear." Well, we all know pink elephants don't live inside people's ears, but to that 3-4-year-old, she really literally thought for a split second that pink elephants lived inside her ears. So how can we be as open and honest to kids at this age group? We need to make sure that we're paying attention to the language that we're using because they pay attention so much to the language that we're using. You know, instead of saying, "Hey, can you hop on this table?" Hop on this exam bed. A table for a 3-4-year-old is a place that we sit and we eat dinner at, not something that we get onto at the hospital. So again, just the things that we take for granted, these kids will actually take literally. Need to offer as many choices as possible to this age group. I think one of my favorite things is when I hear, a physician will say, "Can I listen to your heart?" And the child says no. "Can you take your medicine?" The child says no. We're offering this opportunity for the child to say no. So instead, give as many choices as possible. Would you like me to look in your ears first, or would you like me to listen to your heart? That way they don't have the opportunity to say no. School-age children, these are the kids that play games with rules. They're the ones that need to have the step-by-step information given to them. So it's so important that we offer the most honest information, and we offer it in order of how they will actually perceive or see it when the procedure is done. We want to make sure that we're including the senses. We want to make sure it's step-by-step accurate, and that way when they get into the actual procedure itself, they can predict what's going to happen. Allow an opportunity for the child to ask questions too. They want to become more involved in their care at this age. And then the other thing I really want to highlight is making sure that you offer praise to this age group, any age group as you can, because we want to make sure that that child leaves on a positive note. And so when they come back to our medical facility, or they're in another experience at another facility, they can remember that last experience they had ended positively. Adolescents, just making sure that this age group is in complete control of their care. They want to have decision making be a part of who they are. And so how can we offer that? When you walk into the room, acknowledge them even before you do the parent. Make them be able to answer questions. And so if there's something that they can do as far as being able to have an option, make sure you're offering it to them. And then the other thing I want to highlight about this age group too is just making sure you're always respecting their privacy. It's very important at this age group to make sure curtains are closed, doors are shut, that they have a blanket if they're in a gown, just to make sure you're keeping that respect for this age group in consideration. Caregivers, nobody knows their child best than their caregiver. How can we encourage them to be a part of our care? I think you'll see that so many caregivers come into the medical environment and they're completely overwhelmed by what they are experiencing, that they don't even know how to respond. So we need to make sure that we can decrease their anxiety level, give them a job, and then allow them the opportunity to participate in their child's care. So just like this quote says, research has shown that providing support for family members enhances the psychosocial outcomes for young patients. A parent or caregiver's behavior and anxiety levels are strongly correlated with how a child will respond in hospitalization. So we just need to make sure that we're finding ways to decrease parents' anxiety. And by doing that, empower them in the care that they are about to experience with their child. This is Christian's mom, Katie. She's going to share with us her perspective of what we can do to help encourage caregivers when they come into this environment.
Hi, I'm Katie Boss. I am the parent of a child with leukemia. He is 6 years old, and we've been battling this for about 3 years now. What I would like you to know from a phlebotomy standpoint when a child comes in for a lab draw is to take the time to get to know my child, maybe get to know me a little bit, and what are our experiences with lab draws, what works, what doesn't work, explaining all of the different options that are available at your institution, whether that's distraction techniques, sprays, creams, whatever you may have. And allow the child to make that decision with what works for him or her, and involve the parent in that decision as well. Sometimes we aren't always aware of what is available, if there's something new that we could try. Also, as a parent, giving me a job, it also helps me cope and have a better experience too, and I can feel like I'm doing something for my child as well, to help him through a painful experience. But truly, by asking the child what works and what doesn't work for them, gives them a sense of empowerment too. The other thing is involving the parent in comfort positioning during the poke. Some parents will shy away from it and think that their child might blame them or become mad that they're hurting them, but truly kids really view it as being supported by their parents. And it also gives the parent a job, the child feels comforted, and it allows for the staff to be able to do their job as well. Another important thing to remember is at the end of it, find something that went well and praise the child on that. Even if it was a bad experience, just giving them some positive reinforcement on their way out the door really helps for the next time. Also, having a good experience is so important because some of these children get so many pokes throughout their treatment course that one bad experience can ruin the subsequent ones, and it makes things a lot harder to get your sample.
Katie nailed it. She said exactly what we think. We need to empower parents to be present and to be their champion for their child. We need to make sure that we're offering praise not only to the child, but we also need to offer praise to the parent, because the parent's doing some tough work while they're there too. Ryan's going to talk now about some considerations that need to be taken into account when working with pediatrics.
Yes. Yeah, now that we've heard about the developmental considerations for the different age groups, and we've also heard the perspectives of a child and the parents, and kind of know how everybody is feeling, which is very important to know. The next step is what we need for our resources and things to consider for the lab draw itself. So some of the key aspects is our equipment that we're going to use. So the size of the needle, the size of the tourniquet, so the materials that we're going to be using, and that's going to be appropriate for that lab draw and that specific patient itself. Also, in the amount of collection needed. With infants, we all know that there's certain amount of blood that we can take on a daily basis, and then also being aware of the minimum amounts needed to be able to provide that accurate collection for them. So kind of knowing that ahead of time can always help. I know one thing that has always really helped for me is you kind of go in saying, okay, I need this amount to be able to have the best possible outcome there, but if I'm having a difficult draw, or if I'm not able to get the full amount, that I need to at least get this amount to be able to have the testing. So already having that awareness before you go in, rather than getting to that you're getting blood but not enough, and now you're worrying about how much that you truly need, so I don't have to poke this patient again. So always being prepared and kind of knowing that ahead of time is very beneficial. The environment that you're going to use. Is it somebody that you have to lie down and have a bed, or is it somebody that can sit in a chair either by themselves or with a parent? And then what different pain relieving options that you have at your disposal. I know every institution is different, and the things that they have available, but also being aware and knowing what your resources are and what you do have available can help you prepare in the lab draw itself. So in talking with the pain relieving techniques, there's many different ways. We only highlight 5 of them here, but oral sucrose, excellent for infants. It's basically like a sugar water that helps calm them. Within that same mindset, sometimes even doing a lab draw while they're breastfeeding. They're getting some food and then also being distracted through the breastfeeding. That can be very beneficial. Buzzy. So buzzy comes in different forms. So it's a vibrating, sometimes it's a bee or a ladybug, something that you can strap onto the arm, and it's a vibrating sensation that just kind of helps kind of just numb up the arm, give them a different feeling that distracts them from the poke. Numbing creams. There's a lot of different numbing creams out there that you can put on the site. It's a topical that's gonna just numb the skin, so they're not going to feel the needle when it goes. The one thing to consider when you're using these different techniques is So for the numbing cream, it is going to add additional time. Most numbing creams range anywhere from 20 minutes to 45 minutes that needs to stay on to be able to really numb the site. So also being upfront with the parent with that, if you're being able to offer numbing cream, let them know it is going to take additional time, but it is going to add a benefit to the child. And then depending on the institution, some will have a cooling spray. It's kind of a numbing spray, a lot of the same aspects of the numbing cream, but it's something that's going to be instant, something that you can just spray on the site and be able to stick right away. So that's another one that's really nice, that it's going to have the same effect as the numbing cream, but it's not going to take the additional time. So that's always a good option and stuff too.
So how do we prepare patients for medical experiences? So most kids we find want to know the information. Not all do. And so we will start off by usually just asking them, so tell us what brings you here today, even though we know it's a great way for us to check for understanding for them. And if the child's able to explain what is about to happen, I then ask them, can you tell me a little bit more about what that includes? Because what that does is teaches me what I need to share with them. So let's say that a child is coming in for a lab draw today, and I'll ask them, tell me what brings you here today. And they say they're going to get a poke. I then will proceed by telling them, do you know why your body needs this poke? We always want to make sure that we're telling kids the reason that we're doing these medical procedures is because their body is in need of having an answer for what's going on with their body. We never want to tell them that we just poke to poke, or sometimes we'll have a new diabetic that's been recently diagnosed, and the parents will say, poke me first, poke me first. We try to discourage that from happening because that's showing the child that pokes can happen to anybody, when in the end, pokes happen because your body really needs it. So always explaining the reason of why the poke is going to happen. And then talk about the series of events. That way, especially for that school-age child, they can predict exactly what's going to happen. So today we're going to take this tourniquet and then let the child see that tourniquet, even touch that tourniquet so they can feel what that feels like, and talk about how we'll tie that tourniquet around their arm, and that's going to give your arm a tight hug. And then from there, we're going to take the alcohol pad, and the alcohol pad's going to feel cool, and we're going to wash that area off before the poke happens. Giving that child as much choice in the matter too. Would you like to count before your poke? Would you like to watch your poke or look away? I think that that is something that I end up battling parents for more than I do the child, because the parent will say, no, Sally, you don't want to watch this happen. When in the end, that's how that child copes, is by watching the procedure happen. And so allow that child that opportunity, because that's how they might cope through that procedure. You always want to use the appropriate language. And so again, stay away from big medical terminology that kids aren't going to understand, but offering that honest, simple explanation. That way kids can help interpret what's going to happen to them. There's no magical thinking, and they're able to then predict when they go into that procedure what's going to happen next. We talked a little bit about sensory information. If there's any sense that's involved, prepare them for that ahead of time so they can also predict that. And then help that patient come up with their role or their job during the procedure. So if we're about to do a lab draw, I'm going to tell the child that their job is to hold their arm as still as a statue. Sometimes we even practice what a statue is. I'll have them move their body, dance around, and then be still like a statue. And that way they know what they need to do with that arm when they go into that situation. We'll be in that procedure and that child will start to wiggle, and I'll remind them, keep your arms super still like a statue. If you need to wiggle something, it's okay to wiggle your toes, but keep that arm still like a statue. Again, reminding them and emphasizing what their role is. And then in addition to the child, helping that parent identify what that role is and giving them a job too. We're going to talk about comfort positions here in a little bit, but so often we'll find the parent will get into that safe position, and then as soon as the procedure starts, they start to wiggle and move their body around too. And so reminding that parent, your job is to give your child a hug the entire time of the procedure. I will tell you when it's all done, and then you can pick your child up and give them a hug from the other direction. And then we make that plan and we practice it ahead of time. We get that child in that comfort position, the parent in that comfort position, and we allow that opportunity for them to rehearse it. So if we can see ahead of time, this positioning isn't going to work, we're able to stop that before we get into the actual procedure. So research demonstrates that children are less fearful and distressed when they're in a sitting position rather than laying down. Right about the age of 6 months, when kids have the ability to sit up, that's when I encourage you get them from off their back. You'll find, like, let's take a 2-year-old, for instance. You'll bring them in to get a lab draw, set the 2-year-old up on the exam bed, have them lay down. They start to cry immediately because they have felt like they've lost a sense of control. Get kids in a sitting position. And then involve the parent. We find giving the parent the job helps reduce the anxiety and encourage the parent and the patient satisfaction throughout the procedure. Here's an example of a comfort position that we use with an infant. You see in this picture, mom is swaddling the patient. Mom is looking, mom could be singing, mom could be talking to this patient. Mom doesn't even have to watch these pokes that are happening. She can focus just on their child. Always have a pillow around too, if you can, to help prop mom's arms. If mom was just holding that baby, her arm would be free floating and we'd be setting that parent up for failure, because as soon as that poke happens, mom might move or wiggle. This way we have her in a comfort position. I also make sure that I have a firm backing behind the parent. So in this comfort position, that parent is safely secured with having back support. And that way, if she were to move backwards, the positioning wouldn't allow her to, and she'd be able to be right there with the child. This is a chest-to-chest position that we use often for lab draws. And if we're in the emergency department, we'll have that child swaddle the parent by giving them a hug. The only thing that the phlebotomist needs to do is make sure that there's good arm control. And so maybe having a second person to come in to make sure that patient doesn't wiggle. But this gives the opportunity for the child to watch or to look away. If both parent and child did not want to watch, I would have the parent then put the child's head on the other side of the dad's shoulder here and have them look the other direction. And maybe there could be some distraction and so forth for that child to be able to look at. This can be done both in a chair or on a bed. This is the chest to back position. I would say that in our lab, you will see that this is probably used most than any other position. It's a great position for that child to either watch or look away. Mom can be, or the caregiver can be, sitting in that chair with that firm back support. And then the patient can be easily distracted by looking out. Sometimes, depending on the patient, I will have the mom hold the other patient's arm too and give it a nice hug. That way that hand isn't free to be able to move or even take a swat, which we've had happen in the past. But you obviously want the child to be old enough to understand what's going on in this position. And then if the child is young and needs even more support, I will have the parent swaddle or move back and straddle that patient so the patient can actually, their pelvis can be touching pelvis in a straddle position. And that gives a little more security so that patient can't wiggle around when the patient's pelvis is touching the parent's pelvis. And then once kids get older, we all think Yeah, teens can do it, but sometimes they need just a little extra reinforcement. In this picture, the caregiver is sitting directly next to this young child and is offering their arm from underneath. And this just gives a little bit more security. I was in an exam room once where a 13-year-old said they didn't need their parents. And we had that child sit next to the exam table, and then the chair was right beside it. So there wasn't an area for them to move. But then we had the dad actually sitting right beside them. And as soon as the poke came, the child kept drifting this direction. And it was so great just to have dad be able to scoop her right back. And we had no problems getting it. But it's just natural instinct for us to want to move away from what's happening, and allowing these comfort positions gives kids and parents success for moving forward. Research actually shows there's less staff needed to hold children down when the use of comfort positions is introduced. Comfort positions are something that take practice too, but once you get someone to buy into the concept of comfort position, they usually don't like to go back to putting that child flat on their back. They usually are pretty sold on it, and they realize, wow, this really can work. The child becomes more compliant, everyone's anxiety is down, and we can get this done quickly. Now, are there situations where a comfort position can't be used? Yes. And usually I say it's a 3-strike rule. Number one, I'm going to try it. If that child is wiggling and moving, I'm going to do a strike 1. I'm going to go out and get a second hand to help hold that comfort position. I'm still going to allow the parent to be in that position, but I'm going to reinforce them by having that staff member either hold the arm or come in and show the family what they need to be doing differently while the other person is taking the blood. And then if that doesn't work, I usually tell the child, you're showing us that you're having trouble holding your body still. And because of this, we're going to have to help you hold your body still. And then we usually put them up on that exam bed to do the poke. But again, I remind that child that they made that decision. They're the ones who are deciding by not holding their body still. So they know that that's not something that we would wish upon them. So how do we do it? How do we create a plan? Everything that we've discussed, you take into consideration. Think about the acronym One Voice. One voice should be heard during procedures. It is so easy for all of us to want to chime in to help that parent. Sometimes you're going to have the phlebotomist talking, child life specialist talking, the kids talking, the parent talking, and the stimulation just increases in the room. How can you just have one voice, identify ahead of time before the procedure who's going to do the talking? Have the parent be involved, give them that role, and so they know exactly what they're doing going into the situation. Educate that patient by providing appropriate preparation, and then validate them with words. Sometimes kids will say, is this going to hurt? Is this going to hurt? I'm not going to tell them that, yes, it's going to hurt. What I'm going to answer is, you are the one who needs to decide that. So after we're done with the procedure, you tell us how that feels. Because sometimes even taking a blood pressure doesn't hurt in my eyes, but for some kids, it really is bothersome and they consider that pain. So let that child be the one to interpret the pain. And then also let them know that you're hearing them. I hear that you're saying this is going to hurt. Let us know how that feels. Let us know if that numbing cream works. That way that child can predict or be able to interpret their own pain. And then offer the most comforting, non-threatening position. We do that by a comfort position. Individualize the game plan. People ask me why I like working with peds, because there is no script. And I love that about my job. Every situation is different and every child's going to have different needs. So you really need to individualize each game plan before you go in it. Choose appropriate distraction. Sometimes distraction adds stimulation, so it's not appropriate to have. Sometimes we'll add light spinners, bubbles, magic wands, and the child just needs to be brought down to a calming level. And it might just be having the parents sing a song. Distraction doesn't always need to have an item either. You can get that child distracted by saying, tell me what you're going to do this summer. What are your plans? Is your family going to go on vacation somewhere? Get their mind thinking somewhere else other than being in the procedure. And then eliminate unnecessary people in that room. So here at Mayo, we're definitely a teaching institution that have a lot of people at times in these procedures. For kids, it's, yes, people need to learn, but if we can have as many people that shouldn't be involved in that procedure be gone, especially for those kids that might have sensory processing challenges, because it just creates too much stimulation for them. We're going to take a look at a video of a procedure that's taking place. And while we're watching this video, if you could just think about everything that is causing extra stimulation to this child. Take a peek.
Yeah, come see me. She's like, no, no, Daddy. Do this quick. I know. We're going to do this quick, quick, honey. Oh, just stand up right where you're at. Hey, catch the bubble. Oh, don't worry, catch the bubble. I always did it the first time. Don't worry. Catch the bubble. Catch those bubbles.
Where is Daddy? Oh, he'll be back soon. Daddy will be back soon. He will. Oh, I'm so sorry.
I love watching this video, and I could watch it over and over again because there's so much that's happening in that environment. How many of you have ever been in that situation before? Because I know that I have. All of a sudden, the child gets taken away from the caregiver, gets put flat on their back. There's all these people surrounding. Everybody's talking, trying to tell the child what to do. There's somebody in the background blowing bubbles. The child can't even see the bubbles. And then I don't know if you noticed, the lady on the front is all in this surgical gear. And so it looks like it should be a sterile environment when we know that it's not, because everybody else isn't dressed that way. So much stimulation going on that that child cannot interpret what's happening correctly because they can't even interpret what's coming at them. The caregiver in that situation is so far from the scene, we did a disservice. If you look at all the medical team, we're also doing a disservice by providing too much stimulation. So looking back at this one voice, what could have been done differently? Having one person be the one to talk, having the caregiver involved. No preparation was done with this child. We just scooped her up and put her on that exam bed. And then there's too many people validating words because we can't even hear what the child is saying. We're not offering a comfort position. We don't have a game plan because we're all trying at the same time to make something work. Distraction, too much going on, including the bubbles, which the child can't even see, and all those people that were there. Now we're going to take a look at this concept, this one voice concept, from how it potentially really could be done and see how different the situation looks.
All right, doing the washing, you're getting ready. Okay, now what's the important thing to remember? Hand out here and keep it away from the IV. She'll let you know. 1, 2, 3. She'll count for you, okay? Okay, squeeze the ball. Okay, now Christian, take a deep breath and blow it out for me. Good job. Another one. In. Blow it out. Good job. The needle's coming out, but we still have to hold still, okay? Just gonna try the drink. You doing okay? Okay. Good job.
Doesn't that just feel better for all? It just felt so calming. One thing I want to make note about that video too is notice the patient cried. I think sometimes we leave these procedures and the kid's crying and screaming, everyone's sweating, and we think it was a complete failure. But just because a patient cries doesn't mean that it was a failure. In that situation, he probably should have cried. It probably did hurt for him. Let kids cry. but also recognize he held his arm still like a statue. So that wasn't a flop at all. Even though we made him cry, he did exactly what he was supposed to do.
Now comes your mission, if you choose to accept it. What we're going to do next is provide you with 2 different case studies, and we want you to really think of these situations. These are everyday situations that we've all dealt with working with pediatrics, and just try to think of what would you do in those situations. We really want you to think of that, and then we have a video recording of some of our most senior techs that do this on a day-to-day basis to kind of give their insight of how they handle those situations and kind of see if your mindset goes along with what they're thinking. And then also if you can pick up some additional ideas by what they have to say. So the first case study, so it's a 4-year-old female is at the lab, and she's getting her glucose levels tested. Mom shared with the patient that she's here for a test, but has asked the staff not to tell her about the needle. The patient walks into the lab saying, I don't want to go into this room and I just want to go home. We've all dealt with this where the patient doesn't know why they're there, and mom doesn't want to get them stressed out ahead of time. So they come to the lab. Well, the children, they know as soon as they see the environment why they're there, and it adds even additional stress to all of us. So let's hear what some of our senior techs have to say.
When this happens, we will stand there. I've stood there for sometimes quite a while, just trying to talk to the child and reassure her that it's going to go good. We can try the cream if the parent has the time to wait for the cream or the cold spray, and just try to talk to her, just try to find out what she's most afraid of, to try to help her feel more comfortable with coming into the room and the situation, and just I don't know, just try to talk to the parent to see what has worked best in the past to try to get her into the room. Sometimes we can't get them into the room, but if we try to sit down and talk different options of what we can do to try to make it go better, yeah.
Yeah.
Marnie?
And I think a lot of times too, those are the moments when you guys call me and you're
Yeah.
like, this parent hasn't said anything to this kid. They don't know what's going on. And, they don't want us to say anything about the needle. So that's when we'll come running and engage the kiddo in the hallway. Usually it's that kind of rapport building of like, oh, look what's on Anita's shirt that she's wearing today on her scrubs, or here I've got my light up stress ball and can you hold it? And often we go into the spiel of saying to the parents, we know according to research that when kids don't know what's going on, that they have a much harder time coping than when they do know what's going on. And so we prefer to talk through the steps, even if they don't want us to use the word needle. We don't have to use the word needle. In fact, I don't use the word needle all that often unless the child does. We say poke. We talk about a pinch, the actual feeling that the child will have. And so we do that kind of preparation work again of just talking through each step. If the parent is absolutely insistent that we don't talk ahead of time, I will still do it as it's happening, because you can't not tell the patient as you're doing things, but it's a very easy
we call it a stress point prep, meaning, okay, Anita has this tight rubber band she's going to put on your arm. It's going to give it a hug. It's called a tourniquet, and then, oh, she's starting to touch and feel with her fingers. Oh, now she has a cold, wet wipe that she's going to wipe on your skin. Do you smell it? It smells kind of funny, And then we'll talk about, okay, we're going to have a small pinch. We need to hold our body still. So even if that's all that the parent will allow, that still goes a long way to, especially for a 4-year-old, helping them know what's going on and start to put the pieces together. But I think sometimes helping the parents understand the reason why we want to tell the child, to be honest, so that way they don't lose trust with their parent as well as our environment. Anita talks a lot about, and maybe you can speak to it here, Anita, about the impact for next time. I've heard you say that to the parents a lot.
Yes, next time. And you are right, Marnie. Having a child come in and not know what's going on ahead of time is actually much more traumatic for that child than if you told them ahead of time. Coming in and all of a sudden surprising them with it is, I've seen it so many times. It's so much more stressful on that child. And if they knew a little bit ahead of time about what's going on, I think they're going to be upset, but I think they're going to be able to handle it a little bit more. And just, like you said, Marnie, for next time, let's try to, give a little more information as to what's going on the next time they have to come in, instead of just bringing them in and surprising them, because we get that a lot, actually. And, if you just talk to them, we have children all the time. Well, I want to see the needle. I want to see it. I want to see it. Well, we'll show it to them. The parents don't want them to see it, but honestly, they actually do better if they can see it than if you hide it, because they want to see what's going on. They need to see it, and they're actually, if it makes more sense, they're more at ease being able to see what's going on instead of trying to hide it from them and surprise them with it. Do you agree, Marnie? You've probably seen that.
Yeah, absolutely. And I think giving the child, like we talked about before, giving the child options and choices is really important. So even if it's just I'm holding a squish ball, or I'm holding a light spinner, or I'm choosing which of those two things, I'm choosing to look or I'm choosing not to. And I think helping the parents reframe that to understand it's important that they are allowed to be a participant in this experience, because likely that this is not going to be the only poke that this child has, right? They're going to have immunizations. They're going to have blood draws in the future. And if we continue to have an attitude of just hiding it and not addressing the issue, then they're going to build up that trauma. And every time it's going to get worse, and they're going to fight us more, and they're not going to trust us, and they're never going to trust that parent again, that they're coming. How many times have we heard, oh, I told them we're going to McDonald's, or just to the dentist, or we're going to see a doctor. And so then the next time you say we're going to McDonald's, they're going to think they're going to get a blood draw, or when they're going to the dentist, that means a poke instead. And so we try to help the parents understand this is why we feel so strongly about sharing some information. We can respect that you may not want all specific words used, but here's the words we would use. And I would say, 8 times out of 10, those parents, once we kind of explain that, will ease a little bit and let us do a little bit more preparation and allow the child to be involved. It's rarer that we have a parent that is very forceful about no information. And again, then we kind of do it in the moment anyway. So.
Correct.
So bottom line with that too is, as a caregiver, it goes against your instincts, because you think you're protecting your child by not sharing the information. But in the end, it's doing it harm. And so how can we encourage that relationship building, that trust building, even between the parent and the child, in addition to us with the child, by being open and honest?
Yeah, it's all about being open and honest, and just being able to provide all the options, and being honest with the patient. We want them to have future success. So, case study number 2. We've all been in this situation, I'm sure. First-time mother presents to the lab with a 6-month-old daughter. The mother is already visibly shaken with tears in her eyes. She states to the phlebotomist, "You get 1 attempt and absolutely no digging around. If you don't think you can do this, go get your most experienced tech." Very stressful situation. We've all been there, and let's hear from our experts.
Okay, so first thing I would do is ask mom if she is comfortable with being in the room, because sometimes they don't want to be in there, they don't want to see it. And I would offer for one of our techs to come in and hold the child, and we actually do have parents that will agree to do that because they don't want to watch their child go through that. Others, they want to stay, they want to be in there because they want to be the one comforting their child, and that's understandable. So I would reassure them that I am not going to do the draw. I would not stick the child without being comfortable. I want to look. I want to find my best option. And if I absolutely do not feel anything, I won't stick. I'll get someone else. Another thing that sometimes they're anxious about is they see the amount of blood that's being drawn. And so then we would tell them that it is a safe amount of blood that we're drawing, that we have a pediatric calculator that we can go into, that we actually put in the kilograms, and it will automatically calculate what we need for the draw, how much we need, so that we know we cannot go over this amount. And then from that point, we would cut it down to the amount that we would need. Sometimes they actually have to come back more than 2-3 days, the amount of blood that needs to be drawn to get everything that we need. And sometimes that's stressful, but they understand that it's what we need to do. Also, we reassure them that what we're using, the devices that we're using, are the devices that we use on all of our babies, just so that they're comfortable with what we're using. We're not going to come in with the biggest needle that we have to go after this small child. So, but just to try to do everything that we can to reassure that mom that we are there for the best interest for that baby, and we are not going to do anything to try to harm that child. And if we don't feel comfortable, we will have someone else come in and do the draw. And also, like, again, distractions. We have sweeties that we can use on the small babies, and that makes a big difference. If we can give them something, either dip it on a pacifier or put some in a small syringe where they can put it down the side of their cheek and into their mouth, that really helps. I've actually had some babies that I've done, we've given it to, and they've fallen asleep and didn't even cry, didn't even make a peep during the draw. It's amazing, absolutely amazing. And to have a parent see that, they are just so happy and so relieved and so thankful that it was a good situation, and it makes them more comfortable. So when they do have to come back for more draws for the child, that they're much more comfortable the next time that they come in. Yeah. Marnie.
And our role is typically in those situations, we know that babies feed off of the feelings of their caregivers. And so
yes,
if the caregiver is stressed, the baby's going to be stressed. And then that's when we see the tightening up and the veins get tighter and whatnot. So my role is kind of a dual purpose, not just to help that baby be distracted and calm, which sometimes at that age, maybe they just need calm music and the sweeties, and that's it. They don't need all of the flashy things at 6 months, but sometimes it's more to help the parent stay calm. And so it's explaining, just reinforcing everything that the text says is, yep, we do this all day long. These texts are here to, assist your baby, and you're going to do everything possible. They're going to take their time in looking. It might take some extra time because they're going to spend more time touching and feeling and looking and maybe heating up the arm. They're going to try all of their tricks before they poke. And so we're going to try to be patient and let them find that what that best spot is, and reassuring them of those things. And then again, just helping sometimes with the sweeties or helping with comfort positioning, letting the parents know sometimes they're hesitant to get close to the baby. And so just letting them know, like, okay, mom and dad, you can come right over them and talk in their ear and let them see your face. Or sometimes, again, music therapy is wonderful in these situations. Or if music therapy is not available, I pull up YouTube lullabies on my iPad. And sometimes that calming music, just no words, just calming lullabies or classic music, will just bring the whole room down. And just doing that, that baby calms down, that parent calms down, the draw goes much easier. So really we're there kind of just to reinforce everything that the texts are trying to communicate to these parents who understandably are very stressed.
Very stressed. And to the no digging part, if we do a stick and we don't get it right away, I will always ask first, is it okay if I reposition? Especially if they don't want us to reposition, I would always ask first. And if they say no, come out, then you just come out. Otherwise, if they'll give you the option to reposition, most of the time we're able to get it right away. Sometimes it just, when they move that arm, it just takes a little, the vein has moved just a little bit. So you just need to reposition and you can get right in it. And giving them that option makes the situation better, instead of just trying to go for it, or it just giving options always makes the situation better.
Yeah. So how do we know if we've had a successful mission? We want to go through the checklist at the end of each procedure and to find out, did we have their developmental considerations involved? How much did we involve the caregiver? Did we assess the resources needed for a successful lab draw? Did we reuse the adequate equipment and the environment that we used? What pain relieving options did we offer them? Did we use the appropriate comfort position for them? Was everybody prepared? And it really comes down to reviewing the plan. Just knowing that what we did from start to finish, how we thought that went. And just always remember that even if they cried and they didn't like it when they left, were they able to cope through and get through it? We can't change their perception overnight, but we hope that we keep making it better for them for the next time.
Thank you, Jen and Ryan. We are a bit over time, so unfortunately, we will not have a chance to address any questions during this session. However, you may submit your questions on your evaluation that will be sent to you tomorrow from Zoom. Please note, laboratory credit is extended for this program. Upon finalizing your evaluation, you will have the option to claim credit and print your certificate. If you had registered for this webinar and joined by phone only, please email us at mcleducation@mayo.edu if you do not receive the evaluation. As a reminder, this program was recorded and will be archived on our website in a few weeks. Thank you again for joining us for today's webinar, and have a great day.